I move on to Siddharth. I've saved the best for the last. So now that Siddharth is gradually evolving his techniques of MIGS, especially GAT. So every time I'm coming to one of his talks, there's something new. Today also I saw one of the views of GAT which I've never seen before. It's such an amazing view that if you can have that kind of a view, although I think technically it's going to be difficult because there'll be another person doing it, but it was one of the best views I've ever seen. So Siddharth is going to talk about MIGS and how it's developing, and in the Indian context, where do we really stand? So over to you, Siddharth.
Thank you, Arijit, and it's always a pleasure to meet you, talk to you, and so happy to be here, and thanks for getting me up here. So, when we talk of MIGS, we should always give our pranams to the God. It is not intended to replace trabeculectomy. That we have to remember. Trabeculectomy is the most efficacious surgery for glaucoma, and when you want IOPs in low teens or a patient has advanced glaucoma, this is where you go. However, like any surgery, even Sachin Tendulkar had weaknesses. So like any surgery, TRAB also has issues that can come up over a long-term follow-up. And these bleb related problems and hypotony is something that we can do compensate for by performing these MIGS surgeries. Now MIGS, there are multiple surgeries. So basically you can divide them into bleb forming surgeries and non-bleb forming surgeries, and I will try to concentrate on the surgeries that I have done and is easily available in India. We have already covered ECP, so I will probably be talking about the Schlemm's canal surgeries only. And the surgery that I have maximum experience with is gonioscopy assisted transluminal trabeculotomy. And what you see here is surgery being performed for a phakic eye. The suture insertion is performed, the side port is made at about 90 degrees from the site of intended goniotomy. I am putting pilocarpine because I don't want to go touch the lens. It's a clear lens. And the side port that I make for this MVR blade for goniotomy is right opposite the nasal side, which is gives you the best access. I always use a cohesive viscoelastic or a gel for the intracameral and dispersive viscoelastic on the eye. So everything has to go in first before you put the gonio lens. This is because after gaining some experience, you are confident that you will not struggle with the view. So once you are used to it, you can get the view immediately. And I'm incising the top of the trabecular meshwork with this MVR blade, and once that cleft is created, then I'm just what you can see is pushing the suture in. And when you push the suture in, you always have to remember that you go towards the angle first and then go forward, towards the angle first and then go forward. And this will give you the ability to push in almost 1 complete clock hours of the suture at one go, and within 12 to 15 strokes you will have the suture coming through the other end. The resistance does increase when the suture crosses the 180 degrees opposite side, because the vectors of the force change. You should be feeling some amount of resistance while you are doing it. It should not be resistance free. If there is too much resistance, then you can probably move on from 5-0 to 6-0, or if you are using 6-0 already, then smaller tip of the suture, because you don't want to damage the thing and just come back without. So once the suture comes out of the other end, just pull it over the top and then you rip it. So this is an unedited video of a GAT. It is just played at twice the speed. So once you are experienced, you can finish the procedure in 5 minutes or so, if you remove the time that is required for injecting pilocarpine. So I will just share with you the results that I have over the last 1.5 years that I'm doing GAT. 17 patients completed follow-up for 1 year, and 83 eyes have follow-up for 1 month. I'm telling you both because I want you to know the long-term also. but I also want to let you know that I'm not hiding something by not telling you the short-term results. It does come out that as we are expanding the indications of doing GAT, I am meeting more failures. So earlier I was very carefully selecting. Now we are quite confident that it works in all multiple scenarios. And I will tell you where it doesn't work in my hands. So 4 patients needed additional surgery. 1 patient needed trab in both eyes. She was a young POAG patient, and within 1 month the GAT just failed. The first day IOP was good in both eyes, but then 1 week onwards the pressure was in 30s and 40s, so not responding to medication. 1 patient who already had a phacotrab earlier underwent GAT, again worked for 6 months and then failed. There is 1 patient with uveitic glaucoma who needed goniosynechia because PAS formed. After goniosynechia again the PAS has reformed. I did an iridoplasty for this patient. His pressure on the day when I did iridoplasty, before coming back, it went down, but the patient will come back again on Tuesday, so I am not just keeping my fingers crossed. So if you look at patients who have followed up for 1 month, you see only 3 patients are on medications. So and if it works for 1 month, it is most likely that it will work in the future also. And if you look at the intraocular pressure distribution, all of them are 78 out of 83 are under 21 millimeters, and 41 are below 14 millimeters of mercury. So this is a mix which can work well for certain section of patients. You typically expect an IOP of between 16 to 18, but some patients do better also. And this is the 1 year, 17 patients who followed up for 1 year. 13 are not on any medication. 16 have intraocular pressures lower than 21. 7 of these lower than 14. And I already told you 4 patients needed repeat surgeries. Now, 2 patients where it did not work, I am counting the goniosynechia patient also in this, is uveitic glaucomas. They were both open angle glaucomas, but it did not work for them. So I don't know what is happening. POAG works well. It is very well established. Intraocular pressures are also good. JOAG works in all the 7 cases that I have done. Very interestingly, in PACG, the 11 cases that I have performed, the only 1 patient has follow-up of less than 6 months, and all of them are working well. Now, when the angle is not completely open, or I don't do a GAT, or sometimes it's a mixed thing. I sometimes do a bang also. If the target pressure is not lower than early teens, not lower than mid-teens. So bang I always combine with phaco, and I used to make a goniotomy first before doing the bang. But nowadays I realize that it's better to go to reach the Schlemm's canal and then just rip out the strip. The goniotomy may make you go behind and just making an incision rather than taking out the strip. So you can see that strip here, and I try to perform at least 5 clock hours of goniectomy. And these are the very short-term results of the 60 eyes that I have done the bang procedure for. And there is 1 patient who had a bang done alone. She is a patient who has had a trab, who has had an AGV, and the pressure was still high. So for 2 months now, the pressure without medications is 15 for her. And 11 patients have intraocular pressures less than 16. 6 of them less than 14. So bang seems to be working well, and it is a 5-minute procedure. I'm so happy when I don't have to do a GAT and I have to do a bang. I've become lazier and lazier. KDB, this is, I'm just sharing Rashmi's video, who has this amazing video here. And looking at this video, I could not show this video. So this was beautiful. So KDB has a very, very sharp edge, and instead of just making an incision, you can take a strip out, and that strip really will open up the Schlemm's canal for the aqueous to go through. And you see a very, very wide and nicely defined cleft here. And when we followed up these patients for a short term, they were all working in these for 6 months. Now, this is what the international data is. It's very important to look at this. So any surgery which is closer to this part, it means that that has ended up with a very low intraocular pressure. Now, which are the surgeries? iStent has ended up with low pressure. Zen gel implant has ended up with low pressure. GAT and trabectome, these are the surgeries which have ended up in low pressure when performed alone. When performed along with phaco, it is only GAT and trabectome which have done well. And if we compare this, the starting point for iStent and Zen is quite low, much significantly lower than what it is for GAT and trabectome. So if you want significantly lower IOP and your starting IOP is slightly higher, you would rather do a GAT and trabectome rather than a iStent. It will not take you very low. Now the advantage is obviously you cannot have any post-op interventions to lower the pressure further. Massage will not help, or God knows, maybe helping. Hypotony and bleb-related complications can be overcome. Now, there are disadvantages also, and there has to be a match between your expectations and the reality. So don't expect it to get you pressures of 10 to 12 on a regular basis. That is not going to happen. And some patients, it will not work. Like I'm not going to do it for uveitic glaucomas because clearly it is not worked, and talking to my colleagues, it doesn't seem to be working well for them also. So there is a learning curve involved. You need high quality microscope, slightly expensive instrument. The Grishaber forceps itself is expensive for these procedures for GAT, and KDB is expensive. So if you don't want to use KDB, you have an alternative in bank. If you don't want to use an Omni inject or the iTrack catheter, you have a 50 Prolene suture which you can use for GAT. I will just summarize the recommendations here by looking at the iStent, KDB, Bang and GAT, which are the procedures that are available for us on these 4 different parameters, and rate them from 1 to 3. If you look at it, the iStent is the easiest to do, but it is more expensive and least efficacious. So if you want lower pressure and you want to do something for angle closure, the KDB, Bang and GAT are the options that you can look at. iStent is contraindicated in patients with angle closure. I am very, very excited for these 2 devices to come to us, the Zen implant and PressureFlow, which was in focus earlier. In focus especially because it seems to be working really well, no hypotony. Most patients will have pressure of between 10 to 16. So let us see when we have it and how it works in our population. And I will just conclude here. Thank you, Arijit. Thank you.
Thank you so much, Siddharth. Lots and lots of questions. I mean, I have a lot of questions. I mean, like, if GAT is working so well, why are you looking forward to the PressureFlow or the Zen?
Look, GAT, as you see, it doesn't work for everyone. It doesn't work for everyone, and a significant number of people have pressures between, say 16, 17 to 20s. Now, these are not the pressures that I will be comfortable with when a patient has advanced glaucoma. I will probably put one more medication. So those are situations, those are patients where you want IOPs lower than say 14, 15. You can end up there with GAT. As you saw, 41 patients out of 83 had pressures like that. But it also means that 42 of them did not have pressures like that. So we need something lower. And the other thing is, there is a chance that you can have bleeding inside the eye. So that is a fear that has not left me, and I still wait for the time when the patient will come back tomorrow, especially now when we are doing more and more topical cases. So their eyes are open, it's not patched. So when they come the next day, I'm just waiting to see if it is still clean or is there a bleed. Some
Now you're doing GAT under topical for all patients, like
no, not
no.
but any patient who is good for topical phaco is good for topical GAT also.
Is good for. But during your learning curve, do you prefer topical?
No, absolutely. During your learning curve, the posture of look, when I start now, I know where the head has to go. I have to minimally adjust. But when I was learning, the maximum time was taken in positioning and visualizing. Was not happening. Yeah. So that's the problem with all angle-based surgeries, that you need to develop that skill, and that is why the recommendation that our fellows have to do it for 20 patients in cataract surgeries that they have done. Visualize, go touch the angle and show us the video. With a Sinsky or a iris repositor, go touch the angle, don't damage it. That is also important. So do you have that much control that you can just touch the angle, kiss the angle and come back?
And Siddharth, how are you choosing the patients for bang and GAT?
I am a little reluctant about bang. I was doing a webinar with Dr. Malik Kahook, who has developed the KDB. So I was sharing my results of bang with him. So he said they have actually gone through this process, and these will work really well to start off with, and then suddenly you will find them at 1.5, 2 years later that they suddenly stop working. So I have that reluctance when I don't have any other option, where basically there is extensive pass, then I do bang, and that is why it's all only in angle closures.
How many of your patients have you come across with, significant hyphema post-op with after bang or GAT?
I will show you something. This is something that I have submitted for a photo essay. So I have never needed a procedure for any of the hyphemas. But if you see, this patient had a very significant hyphema when she started. Immediately after surgery, look, this was the worst case that I had. It's probably the connector. Okay. So this was the kind of hyphema that she had, and this was really bad. I was so scared. I was supposed to leave for vacation. I told her that you come and get a AC wash done. I will go into the OR after the OPD and do it for you. But then she was reluctant. She said, "Doctor, can it settle on its own?" And every time she came and I advised AC wash, pressures were fine. And as soon as the visual axis became clear, she was seeing well. I would show her the photograph and say, "This needs to go." She would say, "Doctor, can we wait for 1 more week? Doctor, can we wait for 1 week?" That is how we waited for almost 6 weeks for her. And though her pressure was still fine, we ended up with something that is not described, and that will make me go do the AC wash for this patient. Do you look, the inferior mirror, superior angle, you see a cleft there. But when you look at the inferior angle, you see this pus has formed. This is fibrin membrane which has caused formation of pus here, and this can also happen, and that is the reason now if I see a major hyphema that has not cleared it within a week, I would recommend that you go and wash it off. So you have ASOCT images of this also. So you see this membrane beautifully here. So through this membrane, you can, so that can be an additional reason to not let hyphema be there for more than a week, 10 days or something like that.
And what about any pre-operative anti-glaucoma medications which you would consider stopping? Or for example, like in the post-bang cases or post GAT cases, what do you feel once they start failing? Is it so that some of the medications don't work as well as in a angle in which you have not done any angle procedure?
I think it is true for all surgeries. So when you have performed a trap and it fails, you typically, the medications can't bring it back to the same preoperative level. But it's not very different from usual thing. I think because I have not if it fails drastically like it did in 3 patients that I showed you, there it didn't work. But for most of the others, there are patients who are working on medications also. But the experience, as I said, is not very extensive. We need to follow up over long term. We have a keynote speaker amongst us, and I think I'll just step down from here.